Thanks. Welcome, everybody. As you know, Fremont County is, I guess we're the epicenter right now. We have 8 hospitalized patients that are positive for COVID. We have 4 or 5 patients on ventilators currently. We've done a lot of work out in the communities, both in the county and with the tribal providers and tribal governance, to try to come up with ways to improve our self-isolation and distancing, and trying to keep ill people away from well people. And as you all know, this is a interesting and interesting conundrum that we're dealing with. So our numbers here, as far as the people we're seeing that are presenting to clinics, have continued to rise a little bit based on the clinic numbers. So we're trying to use our clinic numbers as a way to try to get a sense of the prevalence in our community. So that's currently where we're standing. I'm actually doing a reach out to providers, nurses, and other potential medical providers to help assist us if we start to get a overflow of patients. You know, as we all know, the hospitalizations can be quite prolonged, and so trying to figure out how to help the patient all the way through the acute to acute medical care to maybe a convalescent care is going to be a interesting and potentially difficult process. So that's our current status. I'm happy to take any questions if people have any directed ones.
What does that look like hospital-wise? You said you have multiple people on vents. I mean, I imagine you're already probably into a kind of a surge planning situation, or what? How's that going?
Yeah, absolutely. There's been surge planning going on for the last couple of weeks. Also trying to figure out opening up different parts of the 2 campuses here between Sage West Lander and Sage West Riverton to help with that more longer term care. And really, as we all know, probably from many of our facilities, it's going to be staffing, somewhat provider staffing, as well. Our ER docs and hospitalists are really working hard. They've been working, the hospitalists have been working in conjunction with the Casper docs. So we thank you all the intensivists that are helping out. So we're going to need probably some medical staffing to help with that. But I think the bigger issue is going to be nursing staffing and potentially, EMT or CNA staffing as well for more of that longer term care. So that's kind of what we've been planning, surge planning within the facilities, also within the community, coming up with different ideas if they're needed. So.
Well, thanks for your good work down there. Dr. Hill tells me you've been doing a great job down there, Brian. And, if you need some extra providers, I have a day here and there that I can break free of the VA and come down and help.
Oh, wow. Thanks a lot. Yeah, Dusty's been a great addition down here. So, and they've been on the front lines. He's out seeing patients out in the Lander Clinic, out in the parking lot. So yeah, thanks for that. I see Dr. Dowell on the line there, so maybe I should get off the line and let him educate us all. So
yeah. Welcome, Mark. Thanks, Dr. G. Yeah, so I see that Dr. Dowell and Dr. Ganem from Rocky Mountain Infectious Disease and our co-county health officers from Natrona County have joined us, and we really appreciate your time. We know you guys are super busy, but I think a lot of us are very eager to hear your impressions and concerns about Natrona County and the state at large. And I bet you we have a ton of questions for you. So I'm going to turn the floor over to you guys.
Well, thank you for having us. Do you want to start with the questions?
So if you have any introductory remarks, I think that'd be a good way to start. And the easiest way to ask questions is to use the chat box that you can open that by clicking on the chat icon at the bottom of your application. And if folks want to type in questions there, we've got enough people now. I think we've got 51, 52 participants. So if we start unmuting everybody, it's going to get a little crazy. So let's try to do written questions using the chat box if we can. And if you want to just start out by giving us your impression of things as they stand today, I think that'll get the ball rolling.
Oh, thanks.
Sure. So here at the county level, I think we've tried to implement from day one as much as possible measures to prevent outbreaks in congregate settings, and I think that kind of saved our butt a little bit here. We've had up till a couple days ago mostly cases that had been linked to events that has happened outside of Natrona County. As of today, the one problem that we're facing and that indicates community spread is cases at WBI. And we're investigating this. And I think those guys, Dr. Logan, have been really very helpful in setting up a system where when these things happen, we can actually deal with them without, trying not to have like a big spread in those facilities. Just we're working with the EOC, we're working with the hospital, kind of streamlined also the testing through the central lab. We're working to get like more testing capacity to Casper, and we've been told that probably we'll be able to do this maybe hopefully in the next 3 weeks or so. We'll see. I mean, we've been working with the city, the mayor, the commissioners, and like even with the senators and Senator Barrasso and NZ and Representative Cheney. We've been working really a lot on trying to secure PPEs. For us, it's been a challenge. We're working on a search plan. So far, we have had no patients from our county who had to be hospitalized. People who had been with COVID-19 that was basically detected there. We only have, I think, one patient right now that we know of that was positive, and that was a transfer, I believe, from Lander, and he's doing better. It was extubated. That's kind of like where we're at on this.
I'll add a couple of things. Dr. Bogan, one of our partners, has been instrumental in coordinating this in these policies with the nursing homes and with the homeless clinic and the mission. And through cooperation with the county, we have areas both to put people from the mission as sort of a holding area until we get their testing back, if they're highly suspected of having this, and then a second facility that we will put them from the mission if in fact they turn to be positive. Clearly, there's no option in turning them back to the mission. And so that has been coordinated well with the county. Dr. Bogan knows everyone that's working at our 3 long-term care facilities well. And so we've gone back, doubled back on code status of all the nursing home patients who we can make do not transport, because we do not want them in the facility if possible. And through a lot of detailed work and availability of our services as infection guys, we can advise the nursing homes and they can keep some of their patients in the nursing homes rather than have them managed in the hospital if they're not incredibly ill. One other thing that we have been working on is, as a facility, we want to help all our referral hospitals with their patients. And so we have actively initiated tele-ICU, as some of you know. And we're really trying to strike a balance. We want to take patients that are critically ill because we have great ICU expertise, but we also have to look at our staffing, what our ICU can handle, and we have to leave enough room for this, what we think will be a surge within Natrona County. So we continue to try to fine tune that because we're going to have a limited number of ventilators. But I think more importantly than that, it's actually availability of staff to take care of these incredibly complex patients. And so that's an ongoing discussion with all of you that we work with on a regular basis. We want to help, but as much as we can keep patients where they are and not expose transport personnel and everything else to these transfers, we want to do that, but we also want to be there to help on the really ill patients. So that's something else that we're working on. We worked aggressively with a mask policy at Wyoming Medical Center. It took us hours to really get down to how best to distribute the PPE. And those are the kind of things we've been working just a ton of hours on.
Yeah, the other thing we worked a lot on is testing and know who to test so that we don't have like, so we have very clear guidelines on how to test and how to prioritize this. And this has been a moving target, but there is guidance from the state lab on this. We've centralized testing in 2 locations, the Wyoming, the Natrona County Health Department, and the Ristori Clinic. And the Natrona County Health Department is also working with long-term care facilities and congregate settings, including jail and nursing homes, etc., for any testing. So if there is anything going on in these facilities that are actually on lockdown, the health department sends a nurse to go and test them and isolate the patients as soon as they have any symptoms. So that was something also that helped.
And to piggyback on that, by limiting the number of places that are testing, we've set up a system with the help of Anna Kinder who's the director at the county health department. If we get all our tests that are done today over to public health by before 8 o'clock tomorrow morning, we have a transportation system set up. So YDOT or local fire personnel drive it down to the state health department, get it there around noon, and many of our results are out by 7 p.m. with the priority being healthcare providers, hospitalized patients, first responders, nursing homes, following some of those requests from the state health lab. And so we have set up a 7-day-a-week system because it'll really make a difference in terms of how we preserve our PPE and obviously how we interpret our patients and who we can get out and that kind of thing. So those are some of the things we've been doing very aggressively in the last 2 weeks. But of course, we move around and change as things play. But we get the sense, I think, in our county that it's just about to really start to blow up.
Hey, Dr. Stalin-Ghanem, have you opened the chat box yet to see the questions that are coming your way?
I just did.
All right, so you got a few that you could start with there, I think.
Okay, so the first one from Holly Johnson, is that the first one?
Yes, that's the first one.
How does my clinic best see patients? Right now we have a sick hall and a well hall and separate entrances. Is this sufficient? Pretty much. I would say a sick hall, but again, depending on what that sickness is.
So what we have done in our clinic and also try to disseminate in the clinics and the community is one, no more than, depends on how big like your waiting area is, no more than 2 or 3 people there. And you get anyone who comes in and checks in, being screened whether they have any symptoms for possible COVID-19. And if they do, put a mask on and call like a hotline that we've established in Natrona County and maybe go that direction.
But we're screening them also over the phone before they even enter our office, so that they're staying outside. We're asking them questions to see if they're even appropriate to come in the office at that time. And of course, you're going to talk into what else we're doing.
So any patient who comes in, so they can check in and then they go back to their vehicles and they stay in their vehicle until we call them so that we can decrease as much as possible any exposures. Any visitors, the visitors are not really allowed into our facility except one person, say, someone is older who really needs to have someone with them. Only one person allowed in the clinic. Nobody is really allowed in, nobody's allowed in infusion in our infusion suites except the patient themselves. We've also established in our facility a room that is, if someone has respiratory symptoms, kind of like an isolation room with PPE available. So anyone who comes in with symptoms and who has to be seen, because we're an infectious disease clinic. So if you have someone who's got a fever, He probably have to be seen so we know, does he have a UTI or whatever. So they have a mask on, and they're taken immediately into an isolation room. And providers would just go in and assess and determine whether they're at risk or not. And we did a lot of telehealth, which, Medicare and Medicaid has opened the possibility for telehealth. So did Blue Cross, so did Cigna, so did all these guys. So we are doing a lot of telehealth on Zoom. What we do is we send the patients an invite on Zoom to their email, and basically we're just doing a lot of telehealth. More than half of our patients currently are seen on telehealth.
Those are some of the tricks we're using in an outpatient setting. And stuff that we don't have to see a 6-month follow-up, we're delaying if we can.
Yeah, we've cut down more than practically, 50, 70% almost on our elective anything.
We're still willing to see consults. We'll see sick people. We just screen them. We have to see, we're referral guys. We have to see who we need to see, and we'll never turn them down. Next question. How have you been able to coordinate all private MDs? This is from David Fairbanks. I am county health officer in Bighorn, and although our incident command is up and running a couple days ahead of the state orders, we still have had trouble coordinating all the docs to join our meetings. Thanks. We have pretty good buy-in. We have tremendous buy-in in the county, and we've made it through a lot of communication on and ongoing, made it easy for the docs to ask us questions and to know where to send their patients if they're suspicious of infection with COVID-19.
Brian?
Oh, yeah.
About Brian.
About the...
So, Dr.
Go
Vautier.
ahead.
So we've reached out to Dr. Vautier, who's with the Wyoming Family Practice, and we tried to coordinate things through him and our Natrona County Health Department, and through him disseminate the information to everyone who is practicing in town. So the County Health Department has a mailing list of all those guys, and they did set up a meeting and disseminate the information of best practices for screening and flow in clinics and so on. And as Mark said, we've had a good buy-in from most everyone here.
Yeah, and it's just the politics, like we have in every community of any size, medically, have been really thrown to the side, and everybody's really come together pretty well. What we do is message and message and message, and just over and over again, and availability to ask questions. And, it's the same trite comment, no question is stupid. And the knowledge base is variable, and we know that. And so we just try to make it easy and transparent. And there's a whole nother level of messaging. We've done some press conferences. We've worked with the county officials. There's a meeting every day with the county commissioners, the mayor, the city manager, the EOC, so that there's consistent messaging throughout the community. And that's helped in terms of empowering the docs to feel like they're getting help. The meetings at the hospital, in terms of how many we have. Yeah, we can talk about that if you want. Go right ahead. We have infection control meetings, which invites the CEO, respiratory, ER, all the powers that be in this situation. We met for the first 2 weeks every day, 5 days a week. Now we meet Monday, Wednesday, and Friday with a ton of communication in between. And then with the daily meetings with the county, I think we're really coordinating things pretty well. So that's kind of how we're doing it right now. But doc buy-in, everybody should just fall in line right now. There's too much at stake. Okay, next question from Cynthia Casey. We have a patient who was told that her COVID test result was negative, but that she still had a 30% chance of having it. Are any of the current tests really that bad? I believe she was tested by an outside lab.
So the actual sensitivity of the test is depending on several things, including how well the actual sample was obtained. There has been quite a bit of reports of negative test on the first and then a positive on the second. What I would urge here is for people to look into the priority testing and what does that mean. So if we're looking to establish whether we have COVID in our backyard, I think it's obvious that it is here. So if you have someone in the hospital who you really highly suspect that they have COVID, and they're in the hospital, so they are sick with it, and one is negative and you really still think it is, send another one. That's what I'd say. If it's somewhere in the community, I would say regardless, someone who has symptoms probably should quarantine themselves anyhow. You know, people need to stay inside. So really depends.
We have good confidence in the test. I mean, we really do. I mean, that's all we've got to go on. We don't have great confidence in the companies that are trying to market the IgM and IgG serologies, because that in most of the country is really not felt to be all that helpful, and we're not advocating that at all, even though they're hitting up your hospitals and labs for them.
And 30% chance, that's, I think, way too high as far as the false negative. I think the false negative is falling around like 5%
At most.
with the PCR assay that we have available. So it's pretest probability, but only 5. I suspect it to be only 5%.
Thank you. Okay, David, we think we could help in Bighorn County by taking your swing bed patients to free up your acute beds. Could you, swing bed patients, could you clarify that if you're on the line? Let me.
Yes, yeah, I've unmuted. So we don't have in either the two hospitals any ICU beds. So what was discussed with South Bighorn County Hospital, and we have two hospitals, was that perhaps your less acute patients, we could be a resource to take less acute patients.
Sure.
And free up your more acute beds, because
Are you talking about inpatients?
Inpatients or swing bed patients. That's kind of where we see our niche in Wyoming, because we don't have any ICU beds in Bighorn County. So that was our thought.
We appreciate that. We'll definitely look into it with the surge planning that we have.
With the
Really,
CEO, yeah.
Yep.
That's great, thank you. David, would you like, are current recommendations to stay at home sufficient, or should we be pushing for greater restrictions to buy more time to surge ICU beds? What, could you clarify that for me a little bit?
Yeah, so currently we've got strong advice from our state government for people to stay at home and only go out for necessities. We have at least one county with the stay-at-home order in Teton County. My question is whether your impression is that what our citizenry are currently doing in terms of staying at home is sufficiently flattening the curve to give us enough time to build out the ICU beds we're going to need to meet the peak demand, or should we be pushing harder for state government to enact more strict stay-at-home regulations? That's my question.
I don't think we have a difference of opinion. I think I'm a little more aggressive, but would you like to state your opinion first, please?
So I honestly think that the next week or so is going to be crucial. I think we should just there are counties that are more hit than other counties, and in these counties that have like a higher number, the devil is in the detail. Are those numbers all related to one source, or are those numbers related, like what we've seen, for instance, in Lander, you know, when you have like a cluster? So a cluster is a big deal, but a cluster usually is something that you can control. If there is a wide community spread with like 10 different people or 15 different people completely unrelated showing up, that is way more worrisome than if you have like 7 people in one family who get sick. know that, there are significant transmission in Teton County, and I think they enacted their own stay at home or shelter in place. Lander, they said, hey, we may have 400 people who are sick with it, but we cannot test them. We really don't know. I can tell you this, in Natrona County, less than 5% of the infections that we're seeing. So going through the respiratory clinic and going through the kind of
County health.
vetting procedure, to know who we're gonna. So like these are the higher risk to start with. Only 5% of those have been positive. So does that mean that we need to just let our guards down? No, but from all those patients that we have in Natrona County, really over the last couple of days, that we've seen evidence of community spread. So I think overall, as like the numbers go up, we probably should be pushing more for like a more stringent recommendation, like shelter in place. I don't know that at this point with the information that we have, I would say like Natrona County really is not at that level yet. We may get there very quick, but there are other counties that I can see why they would be feeling the need to just like enact it earlier.
And it may be, as you and I talked about before, David, prudent for that to come, like you said yesterday, from the governor and make it uniform in the state. What we have done is, Dr. Ganem and I have talked about this. If we see much more in this county at all, I think we're going to push toward that quickly. But no matter what, we have laid the groundwork with all the city and county officials that this is probably coming. Be ready, prepare for it. So it's already there. We're not going to catch them blindsided. And that's
key, because you want to buy in from, like, I know that when Mark first, got on that decision, and, he did a good job at like canceling the basketball tournament, there was a big pushback and upheaval in the area, saying, basically saying, why would you do this? You got to talk to us first, and you have no authority, etc. And then after that, what we've really established is clear line of communication with all these elected officials, and they are way more in line now with what we think should happen, and that has helped tremendously.
So, David, we're real close.
The other thing, David, that I want to mention is like if we look at like the term shelter in place, every single state has a completely different idea what that means. So to say we shelter in place, but we have like these are exceptions or what have you, I think the devil is in the detail there. I'm with you. I think we're moving quickly to like making recommendations for the higher, like stricter enforcement somehow, or recommendation there. I mean, an order also has to be enforceable, and I don't know how they can enforce these things. But I think it's also important to determine what does that mean. What do we mean by shelter in place? Shelter in place in California is very different than a shelter in place in New York, and so on. So.
Thank you very much, guys. I appreciate the thoughtful response, and definitely echo your concern about the value of getting buy-in from our political leaders and our business leaders, that what we're asking for is the right thing for them too. Because if they don't buy in, we don't really have the physical ability to make them do what we think is right. So you have to convince them, and that can take time, just as you say. And I completely agree that our leaders, especially our governor, is very much on board with this conceptual framework. And I believe that when he issues the order, it will be significantly stricter than surrounding states have enforced, because like you, he recognizes that exceptions sort of undermine the effectiveness of the order. So thank you very much.
And one other point, but to show that there are pockets of individuals in the state that don't get it, there's I guess they're in the House or the Senate of Wyoming. He's from Gillette, and he's the guy that wanted to introduce, to force all of us to see unvaccinated kids no matter what, has now sent a letter to the governor suggesting that we loosen all these restrictions because people are going to get this anyway, and it's more important economically. So I just think you might want to look for that letter if you want your eyes opened as to a subset, and that's a lack of communication. That's something that county has to grab on right then. I've dealt with that guy before, and he is interesting, but that's just a heads up to look for. Okay, Don Gullickson, with an estimated infection rates of 10 to 30% for healthcare workers, are we doing enough to protect them? Are we recommending reusing N95 masks or decontamination with UV or even oven temps of 158 degrees Fahrenheit for 30 minutes? Want to tackle it?
So
we have a mask protocol, by the way,
So-
for our institution. If you want it, we can get it to you, by the way, which will help you, I think, some.
So, okay, so the CDC recommendations are very interesting in this, and you go in there and you see like 3 different like recommendations going from like, you know, in the best case scenarios, if you have like airborne, put everybody on airborne precautions and use your N95 goggles and or PAPR and CAPR. So, but then they go with contingency plans, which I think everyone is in contingency plans now, and then catastrophe plans. And the contingency plans are basically to put patients on droplet precautions, which means you mask the patient. That's number one. Most importantly, if you feel someone has an infection, probably COVID-19, any respiratory symptom, the first thing you do, mask the patient. Before even putting a mask on anyone, mask the patient. That will decrease the aerosolization of the virus. And then mask for the provider, surgical mask, that's what we're talking about right now with droplet, goggles, and gowns, obviously if you have gowns, because we're really down on gowns and hurting there. And then, so these are the droplet precautions that are currently being pushed by the CDC. I'm going to tell you this, you know, there is more and more evidence that the virus has airborne potential. There's been like some studies out there very clear in that regard. And I feel like under any other circumstances, we would be doing airborne precautions for everyone with N95 masks for everyone. We really worked very hard on this, and it took like a long time to come up with a policy. We're more than willing to share with you this policy. I can give you my email or Mark's email.
Or send us your
Or
emails.
send us your email.
flip
Anyone
it.
who wants to do this, we can send you guys the policy that we're enacting at WMC. There is, it's really complicated. As far as reusing also or doing an extended use of N95 masks. The reuse of N95 masks is currently also, we're doing this or contemplating doing it. 5 times is the reuse for people on, you know, so there is a difference between extended use and reuse. Extended use means you put the mask on, you keep it on throughout the shift. And reuse is basically you put it on when you're going to see a patient, you take it off when you're out, you put it on again when you go in, and so on. For airborne precautions, you know, you can only do 5 times of reuse. And every time you do the reuse, what we're recommending is to put a surgical mask on top of it. So you put like the N95 mask, you put a surgical mask on top of it, you go in there, you do your thing, you get out, you take the surgical mask out, and then move on. These are for the higher level of protection. And higher level of protection means someone who has a respiratory failure, someone who you're doing like procedures on, like EGD or intubation, or having nebulizing treatments for them, or having high flow oxygen or CPAP or BiPAP. Because any of those have a high risk of generating aerosolized droplets that are going to be up there in the air. So any of these, we're advocating either PAPR, CAPRs, or N95 masks. For patients who are under investigation and or do not fill into these, we're doing the droplet precaution. The N95 masks are being recycled. There is like our team has come up with a way to recycle them. And there has been like 2 or 3 different ways to do them. One was like use ozone. Another one that they
ozone is what we're actually looking at primarily.
and and there is a whole process in there that is currently in place that we can also share if you guys want.
Or they can contact our sterilization people directly, because they're going to know how to talk about it better than we are.
And maybe we can ask our incident commander who can actually help with all this stuff is Dr. James Bleicher, and I'm sure he will be happy to disseminate that information from WMC. Gosh, I can go on forever on this, but I honestly don't think that's going to be helpful because too much information.
Let me just interject real quick that if you guys would like to disseminate protocols or written information, if you emailed it to me or Sheila, we can get it up on the WMS website for you and distribute it by email blast to every doctor in the state.
I can email it to you, David, after this is done.
Perfect. We'll get that online for you.
Okay, one of the questions, should we move toward universal masking in healthcare workers in clinical settings? In a perfect world, yes. In the real world right now, you got to preserve your PPE, because if we're on the edge of this and we use it all now, we're in big trouble. So I'd say reasonable common sense use in the highest risk areas would be the best way to do it. I think triage of your clinics is key. Doing as much telemedicine as you can, but like we do at Rocky Mountain Infectious Diseases, do a lot over the telephone to see who's sick and whether they need to take one step into your clinic. If they're sick, you got to see them. But if they're sick with COVID, you may not be able to manage them in your clinic. So you should be able to tell the difference. Really, triage and telephone analysis is key right now.
So the 2 things that have happened with triaging the most is, one, we established early in the whole process, we established a hotline with the Trona County Health Department that can triage people and give them, tell them where they are and see if they really need to be tested and offer them testing or not. We've encouraged every provider in town to use that in case they don't know. They can ask their patient just to call that, and we advertised it. The other thing that we've done as far as triaging is telehealth. Use a lot of telehealth with the clinic, with the Ristori clinic, which it really took a lot of pressure off of the emergency room. Because the last thing you want, anybody now who comes to the emergency room is using our PPE. So if you have someone who goes in and I have a little bit of a cough or a fever, you go to the emergency room, you're going to use the PPE, you're going to be in isolation, you're going to have all that stuff. If the same person goes to the Ristori clinic, all what it has to do is like they do an influenza test, and as the season goes down, we may stop doing that, and then get swabbed for COVID-19 if they actually go with the fit the criteria.
Our respiratory clinic, of every 100 that get evaluated over the phone and talked with, only about 5 to 7 are being tested. And so they're very careful in who they test. And I got to tell you, you do not want to be testing really mediocre cases right now when there's so little availability of testing. You really got to go for who you believe is likely to have it. You got to think right now that you got to save it.
What we did is also myself and Mark, we had updated regularly the algorithm for who to test. So that we started with anyone who comes from China and South Korea or whatever, and then we added on things as things progressed to other states, and now mainly what the Department of Health is basically advocating that. The other thing that was super important is we asked every provider not to, when they get a phone call, not to say go to the emergency room, but go through the process. And if any provider wants to send anyone to the emergency room, they need to call the emergency room and let them know, so that those guys know what to expect too.
Because as you'll see in our mask protocol, we're using mask in the ER And what we're doing for our employees that will be starting shortly is we have so many people in the community making cloth masks, including Dr. Gannams, who has Captain America.
Yes, I do.
I wanted Gumby, but nobody
He
can
wants-
find the pattern.
Yeah.
I wanted Barney or
We
Gumby,
wanted
but
Barney, and that's kind of like the
nobody can find it.
So, and we encourage social distancing except here because we're so pure, we're so close to each
but what we've done at Wyoming Medical Center is we're going to have a giant collection of cloth masks for the employees. And if they want to wear them the entire day, there will be a bin. They pick one up, they wear it all day, and then before they leave at night, they drop it into another bin that will therefore be laundered and recycled back into the other bin for the next day. If they bring in their own from home, that it's fair game for the recycle bin, and they won't be able to take it back home. And that gives those that want to wear it a sense of comfort. And there may be some people, but we don't want them walking around in surgical masks and that kind of thing, because that's a big waste of our limited supply. So this was our compromise, and I think it will build some confidence in our employees, especially those that have the anxiety. And that's part of our protocol as well.
And homemade masks really, what we have, when researched with our safety department, the thought of this is mainly it will decrease the shedding from the person who's wearing it. So any visitor who comes through the emergency room right now has to put one of those masks on. When we have more availability, any visitor to the hospital will have to put one of those masks on. So the patients were doing surgical masks on though.
Period. Okay, I know we're running late. Let me get a couple other questions from David. Have you guys read about the University of Florida doc who's using 2 layers of sterile instrument wrap and claims it is N99 standard? A fact or fiction? That's out there somewhere in outer space.
I don't know anything about it.
We would say that's not something we would do, and certainly don't do it around here. Next, would you share your telephone triage questions with the rest of us? You mean from our office? If you're talking about from our office or from the triage centers, they're all the same, pretty much. You want to?
Yeah, we can definitely. I mean, but you may want to just like change a little bit. Until 2 days ago, when we didn't have local transmission, we were asking question anybody who got out of Natrona County for the last 10 to 14 days, we would test them too. But the rest of it is pretty standard, and we can do that.
If you're asking, they're wanting to know for our office. What we're screening for temperatures 99.5, new onset cough, or major change in their chronic cough, because you deal with COPD patients, and we see a lot of weird pneumonias in them. Have they been traveled anywhere? Have they been exposed to anyone else in their family who's ill? Have they been anywhere near someone that's been diagnosed with COVID-19? What else?
New shortness of breath.
New shortness
and
of
then
breath.
The other thing is like, so again, when you do these, you have to ask yourself, what am I trying to achieve? Okay, so if we're trying to achieve the idea that, yes, we want to know in our community what is the prevalence of the disease, yeah, you can test anyone who has any of this. But if we're knowing the testing limitation of the state, and we've been on this conversation with the state health officer and the state lab, they have really hard time. They will have more hard time if we all keep sending everything down to them. So the thought process is like, how is that going to change what we're doing? So mainly if we have patients who are immunocompromised and or living with people who are immunocompromised, patients who have comorbid conditions more than 60 years old or 65, depends on what you read, or who have been in contact with someone with a COVID-19 confirmed case. These and or work in congregate settings. I mean, I cannot stress this enough. Anyone who works in a congregate setting can actually shed things even asymptomatically and or like have symptoms and would get priority. Healthcare providers obviously get priority. any of those guys. So it's all nicely written in an algorithm, and we can share this for you with you guys, no problem. And but that's kind of what we're doing for testing. For our office, mainly respiratory symptoms, fevers. If any of this, yes, we're taking them into this room that is an isolation room, and then go from there and have a provider assess and mask them immediately, obviously. Immediately mask them. Anybody who's got anything, mask them immediately.
Next question. Battelle just got FDA approval to re-sterilize PPE. Can you use your hospital sterilizer to re-sterilize PPE? The answer is yes. And we again encourage you, if you want to contact our people here and talk to them about their protocols, but they've been outstanding. Things like the masks, the PAPR masks and this kind of thing. We were using them, how to clean them, what they're doing with the N95s. There's a lot there. Do we have documented ongoing community spread here in Wyoming yet? Absolutely do. I believe we think, we know there is. We think it's just now really showing its ugly face, because what we're seeing now, of course, is 7 to 10 days ago. So we're just seeing what's already been out there cooking. And so I think it's only going to grow. I really do. And probably pretty rapidly. And that goes back to what David talked about how aggressive do we get statewide. But I have a feeling we need to do this. When we decide to do this, it can't be county by county. The governor's just going to have to step up plate and say, this is what we're doing as a state. We've got to make it uniform if we decide to go that way. Okay. Are there, I don't see any other new questions. Are there any other questions out there for us? Reinfection. I'm sure it can happen, but we don't know what it does or what it means yet. And I bet that if you get reinfected and re-exposed, that if you do get it, should be very mild because you should have some immunity. But who knows? We don't know yet.
So the other thing is the question of shedding and prolonged shedding. Right now, we have people who basically the recommendation is someone with COVID-19, if they have no symptoms for 3 days, such as fever, mainly fever. So they're feeling better, the symptoms are better, they don't have any fevers for 3 days without antipyretics, and they've had like more than 7 days from the start of their illness. You can basically say, okay, you're not infective anymore and you can go, which is questionable at best, in my opinion. There's been like a lot of studies out there, especially in China, which they documented like some shedding up to 30 days. We don't know if those people got reinfected or if those people have been had some reactivation or if they had continued to shed all along. There were some that were tested negative and then tested positive, but this also comes back to sensitivity of the Chinese testing that has not been great. So would this give immunity? We're hoping that it'll give immunity. As Dr. Dowell said, if you get reinfected, it's probably not going to be as bad, but we really don't know for sure. But as of now, we're going with the CDC recommendation as to who can actually go back to the community.
Right.
And if they have any symptom, they still need to put on masks.
Right. At what point are other states putting in place shelter or putting in shelter in place orders, number of infections, and when should we? That's all over the board. There's states with a lot of cases that have not done that, and there are states with not a lot of cases like Idaho and Montana that have. And that's part of the problem in the philosophy and the political philosophy, which we're not going to get into, as to should the feds say we're going to do this as a nation as opposed to leaving it to each individual state. So it becomes it's a very difficult call. Yeah, and the other thing, of course, is the role, what's going to happen in rural areas like us and the spread of the virus versus what's going on in big cities where there are a lot of people obviously concentrated. And I have this sense, and I may be completely wrong, that we'll get some, and then maybe it'll calm down a little bit as the weather gets warmer, maybe with people going outside. But my concern is in rural areas in the United States, are we going to get another hump up when the weather gets cold and everybody goes back inside? Not based on anything other than maybe a little bit of the epidemiology from the Spanish flu, but it's a different virus. We don't know.
I think this COVID-19 is here to stay, and the idea that we can do what the Chinese has done, which is like basically what they claim they do, which is like there is no more COVID-19, and that I think it's not feasible. It's not going to happen. It's not real. My main, and I think this needs to really be discussed at a higher level, maybe the CDC level or what have you, where we need to come to terms with the idea that we may have to do episodic lockdowns or episodic shelter in place or episodic, like what we're doing right now. We're the thing is like we want to flatten the curve, but if, I mean, what does that even mean? And, you flatten it for now and then you open and up in a month or two, and then it just takes off again. So what do you do? Until we have really good medication for prevention and or vaccine, this is going to be an ongoing situation. So I don't think we have an answer for that.
Nope. One other interesting question on here about CPR and COVID-19 patients, should we encourage DNR? Well, we talked about that a little bit earlier, but I think it's important to point out that need to have very good communication with any healthcare provider that's working in a nursing facility or in a disabled patient facility about what is their code status, encourage DNR, what is, can you make them a do not transport so you don't get in a situation a demented 80-year-old lady is brought to your ER with COVID-19 and you're scrambling around contaminating your ER, trying to find family. So it's incumbent upon all providers to have those tough discussions to begin with. And we have really, one of our partners has worked incredibly hard on this and we have a lot of people that now have very clear code statuses. Our ER guys run the CPR and codes in the hospital.
Yeah, that's important.
And they have entire protocols of what do we do when someone codes. Now, we're as infectious disease guys not involved in those codes, but they have entire protocols they're setting up. Dr. Ronald Iverson, he and Dr. Duquette are the head of our ER, have ongoing protocols that they're fine-tuning right now. So anytime we have a code in the hospital in a suspected COVID-19 room or a COVID-19 documented room, and I'm not sure I understand all their protocols at this point. We've been so busy, I haven't had time to go through those, but that's what's going on. I encourage you to call him. He'll share the information with you. It's above our pay grade, but the idea is you're going to aerosolize stuff. You're going to have to be really careful when you're doing that code. That's when a rapid N95 use may be the best way to get in there before you end up, you may not have time to put on your PAPR. You may have to go in there with an N95. That's why you don't want to waste your N95s now. If you got to preserve them. If it gets worse, we're going to need them.
Yeah, so we have, just to emphasize what Mark is saying, we have now 2 different code blue processes going on. A code blue for a suspected or confirmed COVID-19 and a code blue for everyone else. Everyone else, code blue is usually, you have like 8 people in that room. COVID-19, you have 2 or 3 at the most, and everybody is like sitting or standing outside making sure that they can help. The other thing that just like for DNR and what have you, we've engaged our ethics committee, and our ethics committee is looking into what do you do in cases that we have a lot of people on the vent and you have to prioritize someone over someone else, etc. There are articles in the New England Journal of Medicine that came out, a week or 2 ago that actually with a nice editorial that goes into how to prioritize and who to prioritize. So that's work in progress, but we encourage you to look at this also with ethics committees.
Yep.
Real quick add on to the Code Blue process, the other major change for COVID suspect or COVID diagnosed patients is to intubate first before doing chest compressions.
Yep.
Right.
Yep. Yep. You're going back to ABC.
Yep.
Rather than
Yep.
circulation first. Yep.
Yep. And again, in a lot of transfers into us, if they're struggling that much,
Yep. I mean, you don't want
respiratory wise,
to
we're intubating them before they get transferred for that same general reason. You don't want them coding on the plane.
tube them first.
David, you had some about given unknowns regarding duration of rural shedding. Should we require masking of all personnel who are infected and returning after required quarantine? Generally, the standard out there is not, they don't have to do that if they're well and they're meeting all the criteria to be able to return to work.
I would honestly, David, I would just go with what you're saying over there. I mean, but that's not really based on, that would be based on my personal preference, because we know that there is shedding that keeps on going. And I myself feel uncomfortable with people if they just have no symptoms and coughing a little bit, showing up. You need to keep that mask on 14 to 21 days. I mean,
14 is where I think no matter what, 14 days, period, I think, at a minimum. Again, it depends on how much equipment we have and how fast they got well, that kind of thing. That's a tough call. And you said 41 states have shelter-in-place orders now?
It's just, it's probably going to get to the whole country, because I mean, as the numbers are more than 100, maybe 150,000, these are the documented ones. So we know we're probably going to head that direction.
I agree. One other question I'm reading, we need to wear masks and gloves with all patients in the clinic, even well patients. No, it's not correct. We don't do that. It all comes down to triage and questioning and phone questioning. No.
The gloves we use for every patient.
Gloves. Yes.
I mean, we don't touch patient with our gloves, but the mask really is not going to prevent. And it's like the surgical mask. Well, it prevents any splashing getting to someone's face. So I would say, keep your social distancing as much as possible if you can. And you have to use your best judgment. Someone is coughing, in your face. Put a mask on them. More important than putting a mask on yourself, because it can aerosolize things.
But keep track of your mask supply, or you're going to you're going to wish you had some masks when patients come in sick and you don't have them. So I'd be very careful with doing it. I would not make that as a uniform policy. Our absolute lymphocyte neutrophil ratio is useful for following or risk stratifying outpatients. There's something just out saying that if a patient's severely ill with respiratory failure, that if you see their white count going up significantly, up and up and up, that their prognosis appears to be worse. And but there are all kinds of descriptions about lymphopenia being, and leukopenia being a marker of this. And that's great if it's there, but nothing substitutes for assessing the entire case more than that alone, for sure. It can be part of the project, a part of the picture, but you don't base your decision-making on that, for sure. Do you agree?
Yeah, and I talked yesterday with Dr. Kroll, excuse me, Dr. Kroll, who worked in our intensive care unit. He's a Casper native and currently down in Seattle, Washington. And I said, hey, man, is there anything that is making it really easy to recognize those guys? And his answer was no. So really, I mean, it helps, so someone who's got a white count of 30,000 and lobar pneumonia, you're thinking that's not COVID. Someone has a 12,000 with some infiltrate on a chest x-ray, you can't tell, even if it's 12,000. Someone who's got 5,000 with lymphopenia with that's a higher risk, that's a higher suspicion, but I don't think they're seeing any particular pattern that would be reliable enough to distinguish.
Right. Nothing substitutes for history. If the governor asked you today if he should order shelter in place and for how long, what would you tell him? Well, he and I disagree just a little bit, but we work so well together. I would go ahead and do it. I think Dr. Gam said he might wait a little bit, but once we go into it, we'd have to totally decide on duration by the epic spread or non-spread within the state. We'd have to watch every number every day and get a sense as to when it looks like it's leveling off. But I suspect it would be how long? Oh, I bet if you do that, it's a minimum of a month and probably a lot longer.
I mean, and that's the problem all across the nation is like, yeah, we need to flatten the curve, do however we can, but it is how sustainable that is. And I think that's what's on the governor's mind. And societal disruption, you know, I mean, we're in the cowboy state, you know, you have people who may or may not take it well. So I don't want to be in his place or making these decisions, that's for sure.
No. Pediatrics, we're reading about high rates of asymptomatic patients and talking about whether it makes more sense to use liberal PPE guidelines that are in some pediatric practices because of the greater number of kids that are asymptomatically shedding. I don't see how you really do that because you're not going to know which kids are coming in with what that can present the same way. And you're going to lose all your protective equipment. I can't see that masking in that setting is it helpful at all.
You know, the not so nice answer to this is like, don't see them unless you really have to.
Yeah.
I mean, you know, like anything that is elective probably shouldn't, you know, like a child wellness or what have you should not be done right now. Someone who's got a lot of fever, you're really not worried about them having, you know, like, I don't know, urosepsis, UTI and sepsis or what have you, probably not a good time to see them.
But pediatricians, you guys are in the front line. Maybe telehealth and being able to have mom show the kid to you. And you guys are so good, you can look at him and tell whether that's a really sick kid that needs to be seen. I think really working hard on getting additional telehealth might be an answer to that.
There is also a web resource that was developed between IBM and I want to say one of the health systems down in Atlanta that actually we can share also with you. And it's like for families, you know, they can go and they have all these questions that start with, is your child looking well? Is your child unwell? Does he have a fever? And then helps quite a bit in triaging these little ones. And, you know, I know that we have one of our, I mean, we have the link we can share with you. It's with IBM.
And the last thing I see, alterations in code blue for pediatric patients. I refer you to Ron Iverson in our ER, who's 30 years experience in this. I don't have knowledge about what to do with this setting. Do you? He has a protocol, but I haven't seen it.
So for code blue, you know, the system emphasizes that if you are coding someone, you have to do it in an airborne precaution. I don't care if it's a kid or a grown up or what have you. It has to be airborne precaution. So even if there is asymptomatic shedding or whatever, just like needs to be done. I guess the question is like, do you do it on every pediatric patient? I hope that you don't have that many kids just dying on you, but yes, I would.
Yeah. But beyond that, we'd have to have you talk with Ron Iverson.
This is Sheila. I see end of questions. I was going to give a really quick update on testing and some work that the governor is doing. We're having very promising conversations with one company. And so we're hopeful that within the next couple of weeks, we're going to have some testing capacity at some hospitals that are strategically located around the state to alleviate pressure on the state lab, but also increase capacity and reduce lag time. So I think those are really promising conversations so far, and we remain really hopeful that those are all going to come to fruition.
That's a game.
Thank you.
That's a game changer. Yep. Well, thank you very much for asking us to answer these questions. I hope we've helped, and I'll get you the mask protocol, David, and we can disseminate that to anybody that wants it. We encourage you to call sterilization at the hospital and see what protocols they have. I don't know if they're finalized yet, and we're here to help. So
Thank you so much. We really, really appreciate this. And I know you guys are busy, so taking time out of your day to do this means a lot. Thank you.
this is important to us. We appreciate
And
the opportunity.
Dr. Dow, if you want a Gumby mask, my wife's a seamstress. I'll get you one. Thanks
Please,
for the
it would
info.
be, it would,
Don't encourage that.
oh, Gumby is my favorite. I would appreciate that totally.
All right. Thanks again.
Thank you, guys. We appreciate it.
We'll get a recording of this up on the internet as well. So tell your friends if you found this interesting that it'll be available on the WMS website.
Okay.
Last question, I guess for next Tuesday, we're going to keep doing these sessions. Would it be more helpful to have an emergency physician, like if Dr. Iverson were willing to jump on, or a physician from a county hardest hit, maybe like Lander? What would be the preference of the group? Are either of those good options, or even a third option?